Hello guys, today I am going to read about the sepsis form which is created by the HSC Ireland, and this form I will read in two languages. First one English and another is Urdu or Hindi. So I would like to tell you first of all that there are one form and another page is related to the form description, means how to use this form according to this one, these details. Okay, so first one form is like if the person is going to be treated with the sepsis, then after we use this one form. So first of all, when we have done the iNews score like above 4, you can see in this one form that the screen for sepsis, first screen for the sepsis, so we will go for the iNews score. If it is above 4, more than 4, or on oxygen it is more than 4 or nearby that, and then after the patient is on oxygen and their iNews score is less than 4 or less than 5, or patient is immunocompromised, or older person, our patient is in emergency department and screening for the triage, then we will check for the 1 2 3. So what are the 1 2 3 is like the first one is the risk of neutropenia. So we will check the neutropenia, that what is neutropenia means like the neutropenia is the lack of neutrophils in the blood, and it happens because the chemotherapy and radiotherapy, and this treatment we usually give in the cancer. And then after the clinical evidence of new onset organ dysfunction, so there is the one infection and another is sepsis. So infection means entry of the microorganism in our body system, and then multiplication of that one microorganism and create a condition like infection. So that is called infection. But if the organ is failure, there is an organ failure, means like a kidney failure, liver failure, or any other organ failure. Okay, and you can see that there is a lactate more than 4, and also the urine output is less than zero point 0.5 milliliter per kg. Then after we can see that there is an organ failure, because if the person is not responding on the fluid resuscitation, means like you are giving 500 ml of fluid in 15 minutes or 30 ml per kg of fluid, then after still person or patient is not responding on that fluid, then after you can see that the kidney is not responding or the body is not responding correctly, then we can say that this is a patient who is in sepsis. So we will see after that that we can say that clinical evidence of new onset organ dysfunction, that means there is a sepsis. And other is a systemic inflammatory response. If the systemic inflammatory response score is more than 2 or 1, comorbidity means like an other disease like diabetes, hypertension, or any other disease is associated with this one, with these symptoms of the sepsis infection, then after it will be considered, and then after we will go in the white column if there is evidence of 1 2 or 3. Okay, inpatient department, inpatient use iNews escalation and response protocol, escalate to medical review within 30 minutes. So doctor will have to check that patient within 30 minutes. Or if the emergency department triage category is 2, there are 4 categories of the triage. If the emergency department patient has a triage category 2, then after we will complete this form, continue sepsis form and place the chart, name, date of birth, and healthcare registration number. But if there is no evidence of either 1, 2, or 3, then follow usual management pathway. Okay, like inpatient, use news escalation and response protocol. Okay, and then emergency department triage category 3, reassess if deteriorates. If patient is not improving, then after reassess. Okay, because there is no evidence of 1, 2, or 3, that means no neutropenia, no organ dysfunction, and no systemic inflammatory response. Then after, if we have this evidence, then after we will go for this one. We will check the date, time of iNews triage, iNews or triage, iNews score, or triage category 1, 2, 3, 4, and then signature and NFBI pin or the registration number. After that, we will go for the columns A, B, C, D. So A is medical review, site of infection. Where is the site of infection? Means like where is the infection occur? Where you have notified the infection? Either it is a respiratory tract, skin, central nervous system, intra-abdominal, catheter device related, urinary tract, intra-articular bone, or unknown or other site. So in A, we have checked the patient has an infection uh, over skin or in the respiratory tract. We will write over here, and then we will go at risk of neutropenia or new onset organ dysfunction or systemic inflammatory response. Then after, if 1, 2 or 3 ticked, you have ticked the 1, 2 or 3, then after we will go for the is there is an end of life care plan in place where the sepsis 6 would not be appropriate. If no, proceed with sepsis 6. If yes, do not proceed with sepsis pathway, document in clinical area. If infection is present and 1, 2, or 3 or clinical judgment are not applicable, in the form and sign, continue usual treatment pathway, and review diagnosis of if patient deteriorates. Then after, B category is like 6 bundle of the sepsis. We usually follow this one in Ireland and UK. Okay, so time 0. So what are the 6 bundles? In 6 bundles, we review the 3 take and 3 give. So in for 3 take, we will go down in the description area and we will check that what are the 3 take. So first one 3 take or blood culture. So we have to take the blood culture in by using aseptic non-touch technique prior to giving antibiotic unless this leads to delay above 45 minutes. Then after we go for the blood test. Usually we do these blood tests in a normal time, but there are specific like lactate, which is most important. And lactate, if above than 4 millimole per liter after 30 ml per kg intravenous fluid therapy, then after we will check whether the organ dysfunction is there. So the second take is like blood test. So blood test we will take for the blood full blood count, means CBC, complete blood count, in which you will check the hemoglobin, hematocrit, platelets, neutrophils, basophils, eosinophil, WBC. So by WBC, you can assume, and people usually assume that there is some kind of infection, because if the WBCs are raised in the CBC, then after we can suggest that there is an infection, because when the infection occur in the body, when the microorganism come in the body, then after our WBC will activate and uh, make a defense mechanism in our body. So the WBCs will be raised in the full blood count. And then after a renal profile. And the renal profile, we will check about the urea, creatinine, okay, BUN, liver profile, we will check HGPT, okay, and lactate. Then after coagulation screen, we will check PTA, PTT, INR. Other tests and investigation are indicated. Now we will go for the urine output. So urine output, if it is less than 0.5 ml for 2 hours, despite educate fluid resuscitation, assess urinary output as part of volume perfusion status assessment for patients with sepsis, septic shock, start fluid balance charts, catheterization, and hourly measurement may be required. Give 3. IV antimicrobial means antibiotic. We have to give an antibiotic, IV fluid, and oxygen. And by this way, we can cover the most of the part of the sepsis. So if it is going to be improved, then after we have done a good job. So antibiotic, give antibiotic as per local antimicrobial guideline based on the site and source of infection, community or healthcare occurred, and the patient's allergy status. Assess requirement for source control. We always check the allergy status. We always ask from the patient whether you have any kind of allergy from this kind of medicine, from ciprofloxacin, from meropenem, from vancomycin, from any other antibiotic. So if the patient is saying that this I have allergy with this medicine, then after we will change medicine, and we will check first the uh, pre-test pre-dose test, and then after we will go for the administration of the antibiotic. So IV fluid, then after we will go for the IV fluid. So this is the most important factor in management of the sepsis. If we are going for the IV fluid, patients with hypotension, low blood pressure should receive up to 30 ml of isotonic crystallized within 1 hour of presentation. Start vasopressors in patients who are fluid unresponsive. Patients with hypoperfusion should receive fluid to restore perfusion using a bolus review technique. Give 500 bolus over 15 minutes up to 2 liters. Reassess frequently. Boluses may be amended based on clinical context. See fluid resuscitation algorithm. Call anesthesiology, critical care if hypotensive or if responsive to fluid. So, reassess patient clinical response frequently. Reassess and repeat lactate within 3 hours are more frequent. Indicated if the first is abnormal. Achieve source control if required at the earliest opportunity. So, we have given the antibiotic, we have given the fluid resuscitation, we inform to the anesthesiologist, clinical care if hypotensive. If still hypotensive, then what we will do? continue the treatment with the sepsis and inform to the anesthesiologist or critical care uh, team. Thereafter, after all of these, we will go for the oxygen. Only give if needed. Titrate supplementary oxygen to achieve oxygen saturation 94 to 96. Our aim of giving oxygen, our target is to give oxygen until 94 to 96 limits. But in coped chronic obstructive pulmonary disease means bronchitis and emphysema. In these both chronic conditions, we always give the oxygen in the limit of 88 to 92% because the patient will always be a hypercapnic and he will not need that much oxygen to maintain more than 92%. So we will have to check the oxygen ratio in this one. Then after again we will go for the sepsis chart. So we have completed the six bundle. First one blood culture with the aseptic non-touch technique, blood test, urine output assessment, and then we went for the IV antimicrobial means antibiotics, IV fluids, oxygen given. After that, we will go for the medical review. So we have done all over the six bundle administration. Now we will check the evidence of infection and new onset organ dysfunction, including at initial presentation. This is sepsis. Seek senior input as per local guidance. Okay, then evidence of infection without any new organ dysfunction. Before there was an organ dysfunction, we went for the sepsis protocol. But when there is no organ dysfunction, we will go not sepsis. Proceed with the usual treatment or specific infection. Look for signs of septic shock. Requires inotropics, pressors to maintain mean arterial blood pressure above than 65 millimeter mercury. If yes, this is septic shock. Inform consultant or contact critical care. Then after the D option is showing that clinical handover using S bar, identify situation, background, assessment and recommendation. According to these five mnemonics, we use the handover. We used to give the handover to other person like consultant or nurse. This section only applies when handover occurs before the form is completed, which is then signed off by receiving doctor. So doctor's name, MCRN number, date, section completed, A, B, receiving doctor's name, and form completion. Practitioner's name, signature, and MCRN number. The patient's address graph level. So we have covered all over the things over here. At the end, I would like to remind you regarding the evidence of infection and new onset organ dysfunction. The lactate above 4 millimeter per liter after 30 ml per kg intravenous fluid therapy. That shows the evidence of infection or new organ dysfunction. The cardiovascular system, if you are checking the blood pressure, it's less than 90 millimeter mercury systolic, or MAP is below than 65, or systolic blood pressure above 40 millimeter below patient's normal. Then after we also see that the evidence of infection, and then we go for the respiratory system. New need for oxygen to achieve saturation more than 90%. Note this is a definition, not the target. Renal creatinine. We will check the renal creatinine. More than 170 millimeter, our urine output is less than 5.5 milliliter per kg for 2 hours, despite of adequate fluid resuscitation. Liver bilirubin more than 32 micromole per liter. Hematological platelets less than 100, and the central nervous system acutely altered mental status. Any pathway modification need to be agreed by the hospital sepsis committee and align with the current national clinical guideline for sepsis management for adults, including maternity. So, at the summarization, we have checked that there are the three things which are very important to notify at the beginning when you are checking the sepsis: the risk of neutropenia, evidence of any organ dysfunction, and systemic inflammatory response. And then we go for the evidence, and if there is no evidence, then we go for the normal treatment. And if there is an evidence, then go for the A, B, C, D. And after that, we will review all over the sections which are mentioned in this one HSC based document. Alright, so this is all from my side that I have defined the HSC based sepsis form and another the description of this one sepsis form.